All right, guys. So as promised, we are going to talk about advanced EKGs today. Um, I have a lot of people have requested this. EKGs are not something that just comes natural to people. A lot of times it takes practice, practice, practice. So if you would also like some real-time rhythm strips to help you assess and start interpreting EKGs, by all means, reach out and ask. And if I can't find something or if your clinical instructor can't find something for you, I will be happy to find something for you. Or if you just want to ask me, that's okay too. For this particular talk, we're going to briefly review normal sinus rhythm, sinus brady, sinus tach, and what artifact looks like and how to determine if your patient has artifact or if you need to run and grab the crash cart. And then we're going to talk about a fib, a flutter, PVCs, VTAC, VFib, PEA, and something called asystole. So let's talk about this just as a review. Remember, we have ECG or EKG paper. ECG, EKG all means the same thing. It's an electrocardiograph. It is on graph paper. It is read horizontally from left to right. Those tiny, tiny, tiny boxes are 0.04 seconds. 5 small blocks would be 0.2 second, and 5 large blocks equals 1 second. When you count a total of 30 large blocks, you then have a 6-second strip, which I recommend as your ability to count. I prefer the 6-second strip method just because it's easier to count the 30 blocks, figure out what's going on within those 30 blocks, and keep it moving. Again, your rhythm analysis has a very repetitive, very straightforward 1, 2, 3, 4, 5, 6, 7, 8. These are the things that you do in order to determine what's going on with your rhythm. And sooner or later, it takes lots of practice, but sooner or later, you will get to the point where you are doing all these steps and you don't even realize it. Matter of fact, they get to a point, if you practice this more than enough times, you will find that you can look at a rhythm and boom, just like that, know exactly what's going on. So we typically read lead 2. So you will see, like right here, there is the 2, the Roman numeral 2. We are in lead 2. So again, NSR, which is normal sinus rhythm, it starts in the SA node, so we have a P wave. It moves to the AV node, which is our QRS complex. The rate is going to be somewhere between 60 and 100 beats per minute. It will be regular. P waves will be present before each QRS, and then our QRS interval, our PR and our QRS will all be within the normal time frame. So you can either count them by 3 to 5 blocks, or you can count it by seconds. Does not matter which. Also, again, as review to determine regularity, I count how many big boxes occur between each of these QRS complexes, okay? That can be considered regular within half of a box. So even though there's only 3.5 boxes here, 3.5 boxes here, it's still considered regular even though there's about 4 boxes there. Sinus Brady, it meets all of the standards that we just talked about, except the rate is slow. We have less than 60 beats per minute. Okay, so that's where bradycardia comes in, and the sinus part comes in because everything else is normal. It's regular. There's P waves. The intervals are the appropriate time length. Same thing with sinus tachycardia, except it's opposite. It is tachycardia because it is greater than 100 beats per minute. It is same as normal sinus rhythm, except it is fast. So sinus comes into being regular, P waves, the intervals and complexes are the same. The only slight difference that comes in sinus tachycardia is that the QRS complex may be just a tad bit more narrow than in normal sinus rhythm, simply because it is a fast heart rate. So the faster the heart rate, the more narrow those complexes become. So what the heck is artifact? Number 1, there is no need to freak out. Number 2, we double check the lead placement and we double check patient movement. So this one here at the top is a very common form of artifact. It is actually read by your monitor as VFib or ventricular tachycardia or ventricular VFib, which also stands for ventricular fibrillation, or it may be identified as ventricular tachycardia or VTAC. So a lot of times this frequently sets your alarms off, but here it is, guys. Somebody just moved, or they scratched their chest where the lead was, or they have a hairy chest, or something has rubbed up against their leads. The other common artifact I see is this big dip and rise. You see that huge dip and rise. There is nothing abnormal about that. That is probably where the patient has yawned. So they take a big deep breath in and they let it out of the big long sigh. So the second one is typically due to some sort of breathing pattern by your patient. All right, so let's talk about sinus arrhythmia here for just a minute. So sinus arrhythmia has a regular rate. It has P waves. The PR interval and the QRS complexes are all within normal limits. That's where the sinus comes in. The only difference is it is irregular. Okay, it is irregular. So you can see here the very first couple of complexes here. There's 1, 2, 3, 4, 5, about 5 blocks in between them, and then it extends out. It's much further here, and probably further here. Now, the interesting thing about sinus arrhythmia, it is not bad, okay? It is not bad, nor should it be taught that it is a bad rhythm. Most people who take a breath in, release a breath, so it'll change with respirations. It is a normal variation with respirations for us to have an arrhythmia, okay? Also caffeine or nicotine will do this. Every time I have a cup of coffee, I end up in sinus arrhythmia. That does not mean you need to come shock me or cardiovert me. It simply means that this is a normal variation for me. The other thing that I will go ahead and say now, so I do not forget, is that all of these rhythms, doesn't matter how terrible the rhythm looks, assess your patient, please. If your patient is sitting up and talking to you and they're alert, they're mentating, they're perfusing, we do not need to rush out and get a crash cart, okay? They are okay. It is when they change status or they lose the ability to mentate, they lose their perfusion, that we have to be concerned and start running. So, I made a slide for your causes. It's can be caused by a respiratory cycle. So inhale, the heart rate tends to slow down. When we exhale, it speeds back up. Caffeine, stimulants, or anything that causes anxiety. So how do we treat it? Requires very minimal intervention, if at all, and then we just implement some lifestyle changes. So the days I don't have coffee, I tend to not have sinus arrhythmia. So it's just that simple. Now we'll move on to atrial fibrillation. This is when the SA node decides to fire whenever, wherever, and however. So the atria, the top part or the top chambers of the heart, tend to just kind of do their own thing. And occasionally, from time to time, you will see that it just beats a little more frequently. Okay. It just does its own thing. And then eventually you will see that the AV node begins to fire and you will get a QRS complex. Okay, so the S8 node fires whenever it wants to. It's a little more rapid. It is also more of a quiver. So an atrial fibrillation is a quivering of the heart. There's no full contraction. It just kind of shakes and quivers and does its own thing. Now, that's not to mean that your patient will always have that quivering atria. Typically, right before a QRS complex, you will see what is a relatively normal, quote unquote normal, what's normal anyways, but you will see a relatively normal P wave. Does that happen in every atrial fibrillation? Heck to the no, but it does happen from time to time. The other thing here too is it may be very difficult to see your P waves, okay, because you don't know if that's just more of a quiver or if that is a true P wave. So a lot of times you can't get an accurate PR interval, and that's okay. That's what makes this part of atrial fibrillation. The other thing too that I want to say is that sometimes your QRS can be just a little bit on the wider side because we don't get as many QRS complexes. So they may be slightly wider than normal. Atrial fibrillation is known in the nursing world as regularly irregular. What the heck does that mean? That means we can bank on this heart rate to be irregular no matter what happens. Okay, so in my example here, you see where we have these quivering P waves, really hard to tell. We think that's a normal PR interval, but it's really hard to tell. That one's a little off too, but you see there's multiple P waves that are found within the rhythm. Whereas the second example would be normal sinus rhythm. You have the beautiful P, QRS, and then T wave, and then goes back into a heartbeat. Some of the causes of atrial fibrillation include altered electrical conductivity, right? There's something misfiring with your AV and your SA nodes, particularly your SA node, because every time your SA node fires, the AV node doesn't generally fire behind it, as you can see here. Okay, so some sort of altered conduction in the heart. The other causes could be high blood pressure, coronary artery disease. There could be some abnormal labs associated with this, metabolic imbalances. It could be also a lung disease. A lot of our chronic obstructive pulmonary disorders, our COPD patients, tend to have AFib. And then, of course, AFib can be brought on by stress. Okay, AFib is not always a bad thing. My clinical students can tell you we have patients all the time in AFib on our unit. It just happens. My grandma lived in AFib for many, many years, but we have to control AFib. It's when we have something called RVR, or rapid ventricular rate, that it becomes a problem. For the most part, we typically use medications for rate control. So we put them on beta blockers, cardiac glycosides like digoxin, or calcium channel blockers. The biggest thing when we treat atrial fibrillation is that we want to reduce the stroke risk, okay? Because those atria are quivering instead of a full contraction, your patient's at higher risk for developing blood clots. Those blood clots like to go to the brain to cause a stroke. So AFib patients are at highest risk for a stroke. So in addition to that beta blocker that they might be on for rate control, you may also see them on a blood thinner, Xarelto, Coumadin, a couple of different other ones. If our patient becomes unstable, and what I mean by unstable, they all of a sudden have pallor, cyanosis, they're not mentating, they're completely confused, or they completely pass out on you, we have to or electrically intervene on atrial fibrillation. So one of the things we can do is electrical cardioversion. Electrical cardioversion, you attach the pads, you change the defibrillator machine to cardioversion. It syncs up with the QRSs and it learns how to shock the heart back into a relatively normal rhythm. The other thing that they can do is medication cardioversion. So this would be your patient that has an RVR, which I think I put, yes, this is RVR. Okay, what I mean by RVR, it's a rapid ventricular rate. So not only do we have the AFib going on, but we also have frequent contractions of the ventricles, RVR. So in the RVR state, this is where most of our patients become unstable. Although they can be in RVR and they're talking to you, they're alert, they're oriented, they're fine. So we tend to use medication-induced cardioversion when they are alert and oriented. And so medications of that include amiodarone, Cetalol, propafenone, flecainide, and dofetilide. Sorry, those are tongue twisters. The other thing that they can do, if they deem that it's warranted, the cardiac doctor, if this continues to be a problem and these patients are frequently in the emergency room needing electrical cardioversion or even medication-induced cardioversion, sometimes they will go in and do an ablation. And that's where they go in and they pretty much tell the SA node to calm down. The SA node then tends to not fire as frequently. Okay, so again, that's RVR. A lot of times this is where our patients become unstable because they're not truly perfusing. The next one is atrial flutter, and this one more looks like a sawtooth pattern. So the SA node does fire quickly. There are typically a full contraction, which is why this looks more like a normal P wave. Okay, so you see these are just lots of P waves in there. It may or may not speed up the AV node, so you may have a normal ventricular rate, or again, you can have a fast ventricular rate. This is a lot more organized than atrial fib. You can tell it's a lot more put together. Causes of atrial flutter, much of the same except for a couple of changes. Coronary artery disease, hypertension, same as AFib, but atrial flutter can also be due to cardiomyopathy, valvular disease, which means the valves of the heart, the bicuspid and tricuspid valve, are having some issues, usually because they're calcified, or a condition called myocarditis. How do we treat it? We typically want to slow the heart rate. Again, those beta blockers. Because the atria are tending to contract a little bit faster than the ventricles, again, these patients are at risk for stroke. Not as high as our AFib patients, but they are at higher risk for stroke. So they should be put on blood thinners. Again, if they become unstable, we can do that electrical cardioversion. If not, or they have frequent visits to the emergency room because of their irregular heartbeats, they can do the ablation. All right, good old PVCs. These are premature ventricular contractions. As the name states, these AV nodes just kind of fire whenever they want to. It's, again, an electrical conductivity issue. There's some sort of electricity problem within the heart. But here you go. So all of a sudden you have this very gnarly looking wide QRS complex thing that just kind of randomly shows up. There is no P wave before them. There's no T. Well, sometimes there's like a little bit of a T wave after, but there's no P. It's just a random wide complex that happens. So again, these AV nodes fire outside of the normal connection with the SA node. It's a very inappropriate firing, again, very large and awkward QRS complexes. And these only become problematic if we have runs of PVCs. When we have 6 or more beats of PVCs, that is called runs of VTAC. So again, not necessarily a problem. Lots of people walk around with PVCs, don't even know it until you hook them up to a monitor and they're like, oh my God, what is that? It's a PVC. Typically, it might even feel like a tiny little flutter or a skipped beat of the heart. Some people who are very in tune to their bodies might feel them. And again, they don't become problematic until you start having these longer periods of PVCs. Okay, 1, 2, 3, 4, 5 in a row. We need to start evaluating what the heck is going on with this patient. Most commonly, it has to do with potassium issues, hint, hint. So it can be reduced blood flow to the heart that's causing this. It could be a heart attack or a history of a heart attack, cardiomyopathy, low mag, low potassium, stress, anxiety, or believe it or not, patients who are on digoxin. Again, that cardioglycoside can cause PVCs. Typically, I don't have a slide for treatment because most of the time PVCs do not turn into anything crazy as long as we treat the underlying cause. But in the event we don't treat the underlying cause, we can have this lovely thing called ventricular tachycardia. This is where there is rapid electrical firing from the ventricles. So those AV nodes are working overtime. They're very large QRS complexes. Typically, you can't see a P wave. You don't see any T waves. They're just all QRSs, mostly Rs, to be honest. It's an abnormal electrical circuit. It may be so fast that it does not even pump blood, and that's where our problem comes in. So causes of this could be heart disease, heart attacks, congenital heart defects, cardiomyopathy, myocarditis, and my favorite, rising potassium levels. This is the most common one that I've seen, particularly in the medical environment, not so much the cardiac center, because those are more where your MIs and your cardiomyopathy goes. But in general medicine, we tend to find rising potassium levels, particularly in our kidney patients or other metabolic conditions that cause acid-base imbalance. And this is what ends up developing if we refuse to treat, we ignore, or otherwise somehow miss these irregular beats. So the treatment, again, this is really going to depend on what your patient looks like. I can promise you right now that your patient cannot sustain ventricular tachycardia. So they may be in VTAC for like a minute or two, but they are going to very quickly decompensate because we are not perfusing. The heart is not pumping appropriately, therefore we are not perfusing. So we can do a cardioversion. You may see patients get put on an IV beta blocker or calcium channel blocker. And a lot of times this is done so we can slow down the heart rate to see what the underlying rhythm is. So hear me again. Your patient may have ventricular tachycardia. If they are stable, they will give them an IV intravenous beta blocker to slow this rhythm down to see if underneath all of this, there is a P wave happening, okay? We have a very short window of time though, because remember, your body cannot sustain ventricular tachycardia. A lot of times these patients may need an ablation, or they can have an implanted automatic internal cardiac defibrillator. That's what AICD stands for. And in which case it's a defibrillator that's internally implanted into the patient's chest. And anytime their heart goes into this rhythm, that AICD fires and it gets the heart back into a normal sinus rhythm. Now, if you present to your patient and they are obviously not perfusing, i.e., they don't have a pulse, they're not talking to you, they are very unstable, we need to immediately start CPR, call for the crash cart, and as soon as the defib machine gets there, we need to defib this, okay? This is abnormal electricity, so this can be fixed with normal electricity. So shocking immediately, or early defibrillation is an absolute must in this situation. Again, if your patient's pulseless, not perfusing, not mentating, we go straight to defib. Ventricular fibrillation, this is basically the same as atrial fibrillation, except it's your ventricles instead of your atria. The heart muscle just quivers. There is no physical beating of the heart. There is no true heartbeat. It is quick, it is uneven beats. And when you see VFib, you should know defib. So VFib equals defib, means we have to intervene. This is not compatible with life, even for a minute. Okay, VFib is not compatible. Causes would be heart attack. If we have left ventricular tachycardia untreated, they will advance to ventricular fibrillation. Heart disease. I have also seen drug addicts come in ventricular fibrillation, particularly cocaine and methamphetamines. That right there is your absolute reason never to do cocaine or methamphetamines, because it can cause an irregular heartbeat. They are also very good for causing brain strokes, aneurysms. So further proof of why we should not do drugs. But also ventricular fibrillation can come from severe electrolyte disturbances. Again, that potassium, I cannot stress enough, potassium levels should be monitored. Treatment, again, immediately you're going to start on the chest with chest compressions. You're going to call for help and a defibrillator. And as soon as that defibrillator gets there, we need to shock. So VFib, defib. But if you're in there by yourself, you immediately get on the chest and begin CPR. Again, these patients probably need beta blockers to help slow them down once they become stable. Really, when your patients are in ventricular fibrillation, your focus is on CPR. Now, when they come back, we may need to put them on beta blockers, more of a long term, to help keep that myocardial workload down so it reduces the risk of going back into a ventricular fibrillation. These patients tend to get AICDs because if they frequently have VFib episodes, they need to be shocked frequently. So again, we implant an AICD. Or if it's severe heart disease, these patients may need to undergo a coronary artery bypass graft, or a CABG for short. The one thing, yep, I forgot to talk about PEA, so I'm going to talk about that before I talk about asystole. Pulseless electrical activity, or PEA, exactly what it stands for. They look like they have a normal heart rhythm. They absolutely look like they do. They may even be a little bit slow, so they may be like 52. The monitor looks beautiful, but you look over and your patient is dead, y'all. Your patient has no breathing, no pulse, completely unresponsive. They are dead. Okay, so pulseless electrical activity means there's still electrical beats in the heart, but there is no physical muscle contraction, which is totally plausible. If you fail to recognize it for whatever reason, your patient will die and they will eventually lose conductivity of the heart. That loss of conductivity will turn into this, which is asystole, which is absolute absence of any sort of activity. This is a flat line. Now, unfortunately, this can mean one of two things. This can either mean that your patient has completely taken off all their leads and they are standing in the doorway waiting to be discharged, or they could be completely flatlined and have no electrical activity. So again, when you see this on the monitor, please go look at your patient. And if they're standing up in the doorway, it's not asystole, okay? Causes, we tend to drill down the causes of H's and T's for asystole. So H's would be hypovolemia, hypoxia, acidosis, which is known as hydrogen ions to stay within the H's and T's, hypothermia, and it could be hyper or hypokalemia. T's are toxins or drugs, tachycardia, cardiac tamponade, tension pneumothorax, thrombosis, or trauma. Asystole has to be treated. Okay, you have to treat the cause of asystole, or asystole is just going to happen over and over and over again. And unfortunately, this is not Grey's Anatomy, this is real life. So we do not defibrillate this. Okay, the reason why we do not defibrillate asystole is because there's no electrical activity. The only way to defibrillate is if we have some sort of electricity running through that heart. Asystole, there's no electricity. This is CPR and ACLS protocol, which is advanced cardiac life support, with the algorithm of what drugs we give, ratio of compressions to drug administration, and when we call the codes. But you cannot defib asystole because there is no electrical activity. Okay, the only other thing left to talk about, and I'm actually going to do something different for this one because it's heart blocks. Heart blocks are their own little beast. They have their own little difficulty in figuring out what's going on with them. Most of the time, your heart blocks are going to be characterized by a long PR interval. Hear me again. Your heart blocks are long PR intervals. Okay. If you have a patient with a long PR interval, it's going to be one of the heart blocks. So we're going to talk about heart blocks separately just because there are a variety of them. There happen to be three. There's a heart primary, secondary, and tertiary. They're called different things. Winky Bach. I mean, they all have different names. So we'll get into that more in its own little episode because heart blocks really you have to learn heart blocks by themselves because they can be their own set of issues. So anyways, hopefully you found this helpful. Go back, rewind, listen to it again and again. Print out the pictures if you need to. If you want me to send you some strips, I'm happy to. But hopefully you guys have learned something about some advanced cardiac rhythms. All right, I'll talk to you later. Bye-bye now.